Jaundice is an abnormal yellowing of the skin and or sclera due to bilirubin deposition. As you can see, the sclera of this patient is looking very yellow. The increased amount of bilirubin in the blood is known as hyperbilirubinemia that can be due to increased production. The increased production can be due to hemolysis and tumor or can be due to decreased disposition like impaired hepatic uptake and conjugation like and excretion. So the common causes of increased level of bilirubin are hemolysis, obstruction, tumor and liver disease. There is a mnemonic used for it is hot liver. Hot hemolysis, O is for obstruction, T is for tumor and liver is for liver disease. Jaundice, it can be divided into unconjugated or indirect hyperbilirubinemia, conjugated or direct hyperbilirubinemia, or on both mixed direct and indirect hyperbilirubinemia. The unconjugated indirect hyperbilirubinemia can be hemolytic, physiologic, Crigler-Najjar's, or Gilbert syndrome. We will talk about all these in detail in a few seconds. The normal destruction of RBCs occur in the spleen, while if there is increased destruction of RBCs in the spleen due to any cause, that will lead to increased destruction of RBC. As we know, the RBC broken down into heme and globin. The heme eventually converted into iron while globin, long story short, converted to unconjugated bilirubin that is somehow transferred to the liver. So hemolytic is due to increased destruction of RBCs lead to unconjugated or indirect hyperbilirubinemia. Conjugated hyperbilirubinemia is physiologic neonatal jaundice. At birth, there are immature UDP glucuronide transferase. The function of this enzyme is to convert unconjugated bilirubin to conjugated bilirubin. So that's why due to immature UDP glucuronide transferase, there is unconjugated hyperbilirubinemia that will lead to jaundice and kernicterus. The kernicterus is deposition of unconjugated lipid-soluble bilirubin in the brain, particularly in the basal ganglia, occurs after first 24 hours of life and usually resolves without treatment in 1 to 2 weeks. The treatment usually we use is phototherapy that is non-ultraviolet isomerizes unconjugated bilirubin to water-soluble form. So the function of phototherapy is to break down the bilirubin into simple and configurational molecules of that will eventually pass out from the urine, and the bilirubin level in the blood will eventually lose down to the normal. Hyperbilirubinemias are hereditary hyperbilirubinemias that are all autosomal recessive conditions. The first of all, we will talk about Gilbert syndrome, in which there is mildly decreased UDP glucuronide transferase conjugation and impaired bilirubin uptake. The condition is asymptomatic or mild jaundice, usually with stress, illness, or fasting, can occur. The increased unconjugated bilirubin without overt hemolysis and the bilirubin increase with fasting and stress. This condition is relatively common and it's very benign condition. The second hereditary hyperbilirubinemia is Crigler-Najjar syndrome. In this condition, the UDP glucuronide transferase enzyme is absent, so you can say it presents early in life. Patients die within a few years. Findings can be jaundice, kernicterus, that is bilirubin deposition in brain, and increased unconjugated bilirubin. So the treatment of this condition is plasmapheresis and phototherapy. In phototherapy, the bilirubin can be broken down into simple and configurational molecules that will be passed out from the body very easily. So this is a type 1 condition. Let's talk about type 2, which is less severe and responds to phenobarbital, which increase liver enzyme synthesis. A few words about bilirubin conjugation, as the hemoglobin will eventually convert into unconjugated bilirubin that is albumin bind, and water insoluble will enter to hepatocytes. There is bilirubin uptake. The initially bilirubin is unconjugated. There is an enzyme UDP glucuronide transferase in the hepatocytes that conjugate this unconjugated bilirubin, which will eventually known as conjugated bilirubin that is water soluble. So if this enzyme is totally absent, this is called Crigler-Najjar syndrome. If the function of this enzyme is less or decreased, so that will known as Gilbert syndrome, that are the causes of increased unconjugated hyperbilirubinemia. Of jaundice is conjugated or direct hyperbilirubinemia. So it is due to biliary tract obstruction, gallstones, cholangiocarcinoma, pancreatic or liver cancer, liver fluke, the biliary tract disease, sclerosing cholangitis, that biliary cholangitis, the excretion defect is Dubin-Johnson syndrome, Rotor syndrome. Okay, now we will talk about all these a little bit in detail. Bilirubinemia, hyperbilirubinemia is biliary atresia that is a congenital obstruction of extrahepatic bile ducts. By the third week of life, there is total obstruction of the extrahepatic bile duct. So, as you can see, if there is obstruction, what will happen? The bile will move back to the gallbladder and common hepatic duct and eventually back into the liver. So when there is increased bile in the common hepatic duct, so what will happen? That will there is increased pressure, so they will eventually move from the epithelial cells to the blood. So when it is in the blood, it will lead to the yellowing of the skin and sclera. So when there is obstruction, the bile will not move to the intestine and the color of the stools will eventually light. And when there is increased bile in the blood, it will pass out to the kidneys and the color of the urine will eventually dark. Yes. So on physical examination, there is a firm, large, enlarged liver, while on laboratory findings include increased level of direct bilirubin, alkaline phosphatase, and gamma glutamyl transferase. So the diagnostic test of biliary atresia is liver biopsy that will show marked intrahepatic bile ductal proliferation, portal tract edema and fibrosis, parenchymal cholestasis. So the causes of biliary atresia can be environmental or viral, or there is any gene defect. Usually there is CFC1 gene involved in this condition. Finally, let's talk about another type of jaundice, that is mixed direct and indirect hyperbilirubinemia that can be due to hepatitis or cirrhosis. In hepatitis, there is inflamed hepatocytes. So when they are inflamed, as you can say, the function of the liver will decrease. So the overall there is no conjugation. So if there is a little bit conjugation happen, there might be any obstruction. So that is why there will increase direct as well as indirect bilirubin in the blood. So the another cause is cirrhosis. In cirrhosis, there is complete abnormality of liver and the liver function is totally lost, so there will be mixed or direct and indirect hyperbilirubinemia in these both conditions. So you can study by yourself about hepatitis and cirrhosis in more details if you want to know more about that.